So I'm Scott, for those that haven't met me. What we thought we'd talk about is an area where people have definitely differing thought processes in what's best. Post-intubation, analgesia and sedation, whether we should be bolusing our patients or whether we should have them on a continuous infusion. So the concept really is the boluses might lead you to have effective peaks, but then sort of, suboptimal troughs, whereas you might have this nice, smooth, cloud-like effect of a wonderful infusion, but, it has to actually be working. And so how do we actually kind of achieve what is largely considered a standard of care post-intubation, sedation and analgesia? Well, really the devil is in the detail, because each of these have their own pitfalls. I guess the first question is, does it even matter? If you were to take all comers, then, the pros and cons of each might be diluted by the fact that there could be minimal benefits in some of these sort of smaller groups. But actually, I would argue that there's very specific patient groups where there are benefits of either. So let's think from a physiological perspective. So if you've got someone with a bad brain, so that horrible subarachnoid hemorrhage, traumatic head injury, big extradural hemorrhage, really what we are interested in here is defending their cerebral perfusion pressure. So we want to avoid hypotension, which might be associated with big slugs of sedation, big bolus slugs of sedation. And we know from our intubation data that hypotension on induction with people with a traumatic brain injury and a low GCS can double the mortality of the patient in the longer term. So you could potentially extrapolate from that having hypotension from boluses of sedation is probably a bad thing for someone with a bad brain. But then also on the other side, we want to limit spikes in ICP from some of the procedures that we're doing. Maybe that's a thoracostomy, maybe it's laryngoscopy. Those things could also be deleterious to someone with a bad head injury. Also, patients who've got a bit of a dodgy heart. So there are kind of pre-existing diseases that we might find our patients with. Maybe the patient with heart failure is going to tolerate hypertension in the under-sedated patient a little bit worse than all comers would. But then also there's some patients who really tolerate preload quite badly. And so those with severe aortic stenosis, those that have got severe pulmonary hypertension, or in fact, if you're in an in-hospital environment and you're picking up a PE patient who's a bit dubious, that's probably not going to help them if they are having swings and peaks and troughs in the hemodynamics because of sedation and the choice between using an infusion or boluses. The patients who have ventilatory failure, the more observant of you will notice the wonderful yanker that's trying to ventilate this patient. It's one of my favorites, the failure of media to demonstrate appropriate medical care. It's taped in well though, isn't it? It's at least secured, yeah. And so patients with type 1 respiratory failure and type 2 respiratory failure often need a comfortable level of consistent sedation to maintain ventilator synchrony, and that's extrapolated in part from the ARDSNet data on ARDS. And so if patients are inadequately sedated and inadequately analgesed, they buck and they fight with the ventilator, they're dysynchronous, and then the downstream effects of that are either a worsening of their original pathology or can also extend to barotrauma as well. So these are all some of the consequences that we might find. Also, the drugs that we choose and the means with which we administer them can exacerbate an already present problem. So if the patient is shocked, direct vasodilation from the drug that we use, maybe if we choose propofol is most appropriate for this patient, is going to have a direct vasodilatory effect. You've also got effects on negative cardiac inotropy, and then you've got sympatholysis. And how we administer each of the drugs that we choose in our cocktail is obviously going to impact the effect on the hemodynamics from that patient. There's a humanitarian side of things. I think most of us would agree that the concept of someone being aware whilst paralyzed, whilst in receipt of our other services would be akin to a horror movie. So we don't want any of that to be happening. And then you've got really complex situations where there's a lot going on. Maybe you don't have time to draw up an infusion. It's quicker and more convenient to administer intermittent boluses. But then equally, that might be a situation where you then are distracted. You've got a million priorities, and that priority may not be immediately to return to the patient that you feel like you've already stabilized. So there's lots of variables involved in which one should we choose, to use boluses infusions? Or maybe we should use both. Maybe we should use a combination of both. From a conceptual perspective, from a pharmacodynamics perspective and a pharmacokinetics perspective, it would probably be most appropriate for us to give a loading dose of a bolus, followed then by an infusion. But that again compounds the time and the energy, the complexity in programming that all into a pump, working out what dose of bolus you're going to give, and then how much infusion you're going to run on with. So there's a lot of sort of options in here, and a lot of variables that can inform our movements. So I thought we'd have a bit of a look through what evidence exists in this space between, do we administer boluses to our patients in the pre-hospital setting after intubation, or should we administer an infusion? I'll cut to the chase. Basically, there's no evidence in the pre-hospital sphere as to which one is better. There are extrapolated studies from the ICU setting, from the anesthesia setting, but none that are directly relevant to the pre-hospital RSI. On the subject, I guess, of awareness under anesthesia, which is probably one of the things that we would all hope that we can really avoid happening for any of our patients. Again, there's no real data in the pre-hospital sphere. One of the bigger areas to extrapolate from, I guess, is the NAP5 study in the UK anesthetic database, which found in the region of sort of 1 in 8,000 emergent intubations have some element of awareness that's reported afterwards. And again, how that then relates to our pre-hospital environment with patients who are multiply injured with severe head injuries is really hard to say. So it's definitely something that has to be explored further. One of our colleagues in the Newcastle area, Brad Sheridan, that many of you probably have worked with, is working on some things at the moment. There's some stuff at Kent Surrey and Sussex. So it'd be really interesting to see how that sort of pans out, and an area to watch moving forwards. So I thought I'd at least have a look back and see what our current guidance is. So this is the Pre-Hospital Anaesthesia Manual of 2018, and of reference, the 2019 Pre-Hospital Emergency Anaesthesia, the CPS, doesn't actually make reference to post-intubation sedation and analgesia, but the Anaesthesia Manual from 2018 does. And this is broadly what it says. It says an option of using fentanyl for an analgesia as a loading dose, then followed by an infusion or incremental boluses thereafter. Midazolam or ketamine from a sedation perspective, either intermittently or as an infusion, and then intermittent doses of rocuronium, and then seeking signs of awareness or under sedation. But this still leaves quite a lot of scope for clinician choice, which maybe is good, but also variability from what, if we think about what could be best practice, even though we may not know, it leaves a lot of variability from that. So then if we take a step back and think, well, we've got a problem that we want to optimize in a service. If we think about how can we optimize post-intubation sedation analgesia, I guess we need to start from knowing what is best practice. And at the moment, we don't really know. So it's really hard for us to tease apart. But it might be at least wise that we can start with the point of saying, well, when we're actually coming to intubate our patient, should we have at least had a discussion about our post-intubation sedation analgesia plan somewhere in our checklist? Maybe that's going to slow down the whole process, or maybe that's going to mean that we provide better post-intubation sedation analgesia to our patients in the pre-hospital phase. I guess the worst thing is that we end up all high-fiving ourselves whilst the patient's not sedated or getting analgesia, which I think would probably be the worst thing. So I thought I'd open to the room. I'm sure there's some opinions from lots of experience in the room. What do you do? What do you feel works best? What do you feel is achievable in the pre-hospital sphere? Any thoughts? Yep.
I'm with you.
Yep.
Depends how much time I have to spend where we're going.
Mm-hmm.
And if I have a Nikki in the back of someone's head.
A lot of logistics involved in that. Yeah. Do you have a cutoff for how close to a receiving centre you are as to when you would choose one or the other? Or is it a sort of a gestalt, a bit of a gut feeling like, oh, we're close, we'll just use some boluses?
Yeah, it's purely I think just how I feel at the time. If we're 5 minutes around the corner and I've got something left in my syringe, then I'll use that. And if I don't, then I'll draw something up.
Yeah.
I don't know if anyone else, it's not, I mean, I'm quite a simple person, so I go on that. I don't know how anyone else.
In the simplicity?
I think,
in
the vein of simplicity, I tend to start infusions because I don't have to think about that again. So that from that side of simplicity is that it's not something that I'm going to forget, but it would be more like a 20-minute sort of trip rather than a 5-minute. And it also, as you say, it depends on your competing priorities and what else you have to do. Yeah. So I think lots of variables come into it, but I do try and get it done, particularly just with the Nicky and a pre-drawn, and always have the minimum volume extension tubes in my pocket. So it's really quick and straightforward, just to, as you mentioned in your presentation, for the point of cognitive offloading.